Right. Good morning, everyone. It's a great pleasure to be here, and many thanks for the invite from Cardiomyopathy UK. So I'm Dr. Gerry Carr-White. I'm the cardiovascular clinical director at Guy's and St Thomas's. I run our inherited cardiac diseases unit. And I guess just before I go through the talk, just a quick word about Cardiomyopathy UK. So it's quite a small charity, but it has an absolutely fantastic team. And for the number of people in the team, the outputs of the charity is absolutely incredible. So great credit to everything they do. So just thank you to them. And for those of you that are logging in and joining the conference today, you know, anything you can do to help support them would be much appreciated, I think. So I'm going to talk through dilated cardiomyopathy this morning. It's a 45-minute session. We'll give a brief presentation for probably about half an hour, and then we'll spend 15 minutes at the end going through your questions. And then there's a separate talk a little bit later on in the day about drugs in dilated cardiomyopathy, which I think is incredibly important. So if you do get a chance to join that as well, we'll spend a lot of time going through the drugs you should be on, the doses, the ones you can stop, and how you take a sort of bit more control of that. Okay, so cardiomyopathy. So cardiomyopathy just means a problem with the muscle of the heart, and that it's not due to blockages of the coronary arteries, high blood pressure, or valve disease. So that's all a cardiomyopathy is. That's just a definition of a problem with the heart muscle. And when you then try and split it down a little bit further, you just define the cardiomyopathies by what the heart muscle looks like. So you can see on this slide, we have the different types of cardiomyopathy. So in hypertrophic cardiomyopathy, this left ventricle, which is the main pumping chamber, is thickened. But in dilated cardiomyopathy, this left ventricle, which pumps the blood around the body, is dilated, so enlarged, and weak in the way it pumps. So dilated cardiomyopathy just means a left ventricle that's bigger than it should be and weaker than it should be. And this is what it looks like when we do the different scans that I'm sure a lot of you will have had done. So on the top, you have the MRI scans. You have a normal heart on the left, and on the right, you can see this chamber here is bigger than it should be and is weaker when it's pumping. And again, here with the echo, so the ultrasound scans that I'm sure most of you will have done, this is a normal heart. You can see how it's pumping. And then here on the echo of the dilated cardiomyopathy, you can see the way it pumps is much weaker, and that chamber is bigger than it should be. So that's what you see when you look and do the scans on people with dilated cardiomyopathies. Now, there are some people that have weakness and an enlargement of the right side of the heart. And on this MRI scan here, that's what you're seeing. So this is the right ventricle. This is the chamber that pumps blood to the lungs rather than around the body. And some people will have these right ventricular cardiomyopathies. It can affect this right ventricle and often the left ventricle as well. Okay, so how common is all of this? Yeah, so if you look at the different cardiomyopathies, dilated cardiomyopathy, it is somewhere between probably 1 in 300 and 1 in 500 of the population. So it's really common. So if you look at the UK, at the sort of highest estimate, you're talking about a 250,000 people in the UK. And of that 250,000, I think probably 50–60% don't know they have it and aren't under sort of regular medical follow-up. And that would be the spectrum of people with milder disease. Okay, now this is a very important slide for patients and the medical team. So here we have the cardiomyopathies. here we have the different types. So we have dilated cardiomyopathy. Now, dilated cardiomyopathy is just a description. That's just saying your heart is enlarged and is weak in the way it's pumping. It doesn't say what the cause is, so it's just a description. So what you have to do as medical team and patients is go down these next two lines. And a lot of people don't do this. So you have a dilated cardiomyopathy. What you've got to say is that genetic? Does that run through the family? Or is that not genetic? And when you've done that, you need to come down to this line below. So if it's genetic, is it worth us looking for the gene? If it's not genetic, then can we find the underlying disease, particularly if there's a specific treatment for that underlying disease? So for you guys that are patients with dilated cardiomyopathy, if you don't know, you've got to ask your doctor, is it genetic or is there a different underlying cause? Is it a viral myocarditis? If it's genetic, should we look for the gene? If it's not genetic, what's that cause? So that's a really important slide, I think. And this is a complicated slide, but it's just showing a sort of fairly simple principle. So there's a whole spectrum of dilated cardiomyopathy. There's not really a concrete cutoff. So it goes from people where the heart's just a little bit big but isn't weak, to those where the heart's a little bit weak but isn't big, to those that have a big and weak heart. So there's a whole spectrum. And a lot of people with dilated cardiomyopathy have very mild disease that often doesn't progress, with a slightly big or slightly weak heart. So there's a whole spectrum of how it presents. Okay, I just want to spend a bit of time explaining why dilated cardiomyopathy and heart failure are different. And this is a really important concept, because often when you start looking on the internet and speaking to people, people think this is the same thing, and it really isn't, because the outcomes are very, very different. So heart failure is someone that has symptoms. They have to have symptoms. So you have to be breathless, tired. You have to have swollen ankles, swollen tummy. You have to have physical signs. When we examine you, the veins in your neck are high. We hear things when we listen to the lungs. So for heart failure, you have to have signs and symptoms, and then you have to have some abnormality of the heart muscle. And that could be a dilated cardiomyopathy, but it could be a previous heart attack or a whole host of other things. So heart failure is signs and symptoms due to a whole variety of causes, of which dilated cardiomyopathy is one. And when you're defining heart failure, it's split into types depending on this thing called ejection fraction. So ejection fraction is basically percent of blood that left ventricle, the main pumping chamber, ejects in one beat. So normal isn't 100%, normal is about 60%. And then we split heart failure into these different types. So is it reduced ejection fraction, which is 40% or below? Is it preserved, which is over 50, or is it mid-range between the two? And that's incredibly important, because all the medicines we give for a big, weak heart are only effective if your ejection fraction is less than 40%. Your ejection fraction is above that. If your heart is too strong to benefit from all the different drugs that we often give. So they're the different ranges of ejection fraction that we use for heart failure, but they're the same cutoffs we use in dilated cardiomyopathy when we're deciding what drugs we should give people. And to really decide that, you do need an accurate number, an accurate ejection fraction. And often the echo, the ultrasound windows aren't always easy. And so if they're not easy, we sometimes give contrast with the echo, which is what you're seeing here. This is contrast with a 3D echo. But again, if they're not clear, you need a contrast echo, you need an MRI, and even a CT scan can tell you. So you do need an accurate ejection fraction to decide if you need drugs, devices, and all the other things that are important. Okay, so this is if you take people with heart failure and look at the causes, the commonest cause is heart attacks and blockages in the coronary arteries. But dilated cardiomyopathy is probably the second commonest cause. And below that will be all the different causes of dilated cardiomyopathy. So when you present with problems, the first step in making a diagnosis of dilated cardiomyopathy is to be sure it's not due to coronary artery disease. So often you'll have an MRI scan, which is what this is. And this white scar here is a heart attack. If you see that, the weak heart isn't a dilated cardiomyopathy, it's due to a blockage of one of the coronary arteries and a heart attack. Most people know they're having a heart attack, but up to 20% don't and just present with a weak heart and don't realize they've had a heart attack. And that's why these tests are really important. Sometimes we look at the coronary arteries with a CT scan, and that's safer than having the angiograms where you go through the angiogram laboratory. And you can see this is an invasive angiogram. There's a tight narrowing in the left anterior descending artery. But you see it just as well on CT scanning. If people have a stable heart rate, we can get pictures like that in the vast majority of people now. Okay, so if we think back to that slide about dilated cardiomyopathy, so you've seen your doctor, they found that pumping chamber is enlarged and weak. They've excluded blockages in the coronary arteries. So you now have a diagnosis of dilated cardiomyopathy. So we now need to come down to that next level on that diagram. So what's the cause of the dilated cardiomyopathy? So here is a rough overview of the different causes. Okay, so it's often genetic, but it can be infection, and that tends to be viral infections of the heart and what's called a previous viral myocarditis. You often see a bit of scar on your MRI scan when you have that. And we have to put COVID in there now, so COVID does give you a longer-term dilated cardiomyopathy. There's these autoimmune diseases, a whole list of them, things like lupus, scleroderma, myasthenia. So they can give a dilated cardiomyopathy, and they're important because there's often specific treatments, such as steroids, toxic and overload, alcohol, cocaine, cobalt, carbon monoxide. Alcohol probably the commonest. If it is due to alcohol, really gets better if you stop the alcohol. We then come on to different drugs. Often the chemotherapy ones, Herceptin and things for breast cancer. But there are other drugs. There are drugs for mental health issues like clozapine that can definitely do it. There's metabolic causes, problems with your thyroid and other endocrine causes. And then in young women, you can get it related to pregnancy. So there are a rough overview of different causes. Sometimes you don't find the cause and it's labeled as something called idiopathic. A lot of the idiopathic ones are probably genetic, but we just don't know the gene. Right, I do want to spend a few minutes on this slide. But when people get labeled as dilated cardiomyopathy, it's a real shock to the system, and people want to know what's the future hold, how long am I going to live, what does this all mean? And if people then Google heart failure, they just see these very, very depressing statistics about how long you'll live and what the outcome is. And it's really important that doesn't apply to dilated cardiomyopathy. And I'll explain that on this slide. So if you look at people in our national heart failure order, these are people that come into hospital with heart failure, and you follow them up. half of them will have died over the next 3 years. So the outcome for people coming into hospital with heart failure this year, last year, is very poor. But this is a group of people, most of whom have kidney problems, lung problems, have had heart attacks. And the average age of this group is now 80. So when you look at the national heart failure outcomes, it's an old, very comorbid group that drives those bad outcomes. If you look at all comers with dilated cardiomyopathy, and 90%, and you can see how things have improved. These are decades of treatment. And actually over the last 20, 30 years, the outcome has dramatically improved in dilated cardiomyopathy. So if you take all comers with dilated cardiomyopathy, at 10 years, 90% of them are alive and well. They haven't died, they haven't had a heart transplant. So the outcomes in dilated cardiomyopathy are really, really good and increasingly improving year on year. So they're not the same as the outcomes from heart failure. So I think if you're going to take one thing home from this talk this morning, it's that the outcomes in dilated cardiomyopathy are really good these days, and they're completely different to anything you might read about heart failure. And of course, there is a high risk group that are at a higher risk, but most people do really well. The other thing that heart failure audit shows is the dramatic response to medicine. So your outcome is so much better if you're on the right medicines, the right dose. And I'll do a session later on today on medicines, but they're absolutely key to dilated cardiomyopathy. It transforms your outcomes. You've got to make sure we get those right. So let's just go through the management. So when you see your team to manage it, there's a whole lot of things they need to go through. There's symptoms, risk of complications, genetics, so family screening if appropriate, genetic testing if appropriate. And they've got to check the structure of the heart, the blood supply and the electrics, and make sure they look at all of those. So we just do a little bit on the genetics of dilated cardiomyopathy. This is just a slide showing the cardiomyocytes of the muscle cell. And there's different bits of it that genetic abnormalities can affect. So you have the sarcolemma and the sarcomere, you have the nucleus, you have the nuclear membrane, and there's genetic changes in all of these areas that can give you a dilated cardiomyopathy. But the key thing is this interacts with everything else that's going on. So you have the genetic spelling mistake, but that interacts with your diet, with your blood pressure, with other genes, and the two of them together is what gives you what's happening to your heart. So it's not just a single genetic thing that does the same in everyone. It's part of a whole system that then gives you problems in the end. So should you have gene testing? So the yield of gene testing is different in different cardiomyopathies. If you have long QT syndrome, that the yield is really good. Dilated cardiomyopathy, that the yield isn't so good. So if we look at people with dilated cardiomyopathy, we can find a definite pathogenic spelling mistake, maybe in 30% at the moment. If you don't have an identified gene, doesn't mean it's not genetic. It just means we can't find the gene. So it's often worth looking, but the hit rate is sort of less than half it is, say, with hypertrophic cardiomyopathy. And this is just sort of going back to what I was saying. So you have this spelling mistake in the gene, but there's all these other factors that give you how weak or how dilated your heart is. And that's really important when you're thinking about the family. So if you have a sort of bad dilated cardiomyopathy, it doesn't mean your children would also have that. And vice versa, if you have a very mild cardiomyopathy, it's still possible that your brothers or sisters could have a more severe one. So the same gene in the same family will do completely different things often. So what do we do about family screening? And a lot of people obviously worry about their family. So if you have a dilated cardiomyopathy and you haven't found any other cause, so there's not a previous viral infection, it's not your thyroid, it's not alcohol. If there's no one else affected in the family and you screen the family, you have about a 1 in 3 chance of finding abnormalities. But most of the time they'll be mild. So of that 1 in 3, only about 1 in 3 of those will develop significant disease that needs any treatment like tablets. So if you have this so-called idiopathic dilated cardiomyopathy and you screen family members, you've got about a 1 in 9 chance they'll have a cardiomyopathy that needs treatment. And when we're thinking about when we screen the family, you either start for children, start at 5 or 10 yearly through adolescence, then probably every 3 years going forward, and maybe stop when you're about 65. So it's quite a long process of family screening, and that's why if you can find a gene, it's really helpful. Because if you find a gene and family members don't carry that, they don't need any more screening. You can stop that whole process. If you have a family where other people have a dilated cardiomyopathy, then it's what's called autosomal dominant. So first-degree relatives would have a 50-50 chance. But the screening pattern and how often you do it would be the same. Okay, so management, I'll just spend a little bit of time going through that, then we'll go through some of the questions. So management of dilated cardiomyopathy. So there's the non-pharmacological measures. So understand your disease, understand your tablets, keep an eye on your weight, particularly if you tend to put on fluid. Just a normal amount of salt in your diet, you don't need a low salt diet. Fluid restriction you only need if you're putting on fluid, if you're getting edema or very breathless. If you don't have that, you don't need to limit your fluid. A bit of alcohol is fine, but take it easy, don't have too much. Exercise is important. I'll come on to that in some of the questions. Don't smoke. A lot of people want to ask about sex and things, but don't. But that, if you can walk up a flight of stairs, then sex is absolutely fine. And erectile dysfunction is really common with a lot of the dilated cardiomyopathy drugs. And it's very treatable, and you often can change the drugs around. So, if there are issues, please do raise them, because they're all very treatable. Must have your immunizations. I think a COVID vaccine will be a while, but definitely have that when it comes out. An exercise should be tailored to your specific cardiomyopathy, but is really important. If there's a rehab program you can join, please do join it, and they can help fine-tune it for you. But you don't have to be crazy, but if you can do it 3 or 4 times a week, you can mix aerobic exercise with stretching core stuff like yoga and Pilates, and a bit of light resistance work, particularly as you get older, to keep your muscle mass. It's the combination of all 3 of those which is the most effective. Okay, so if you have dilated cardiomyopathy and a reduced ejection fraction, so less than 40%, that's when we start these tablets for you. So we give ACE inhibitors and beta blockers. And if you're still symptomatic on that, we add these mineralocorticoid antagonists, a spironolactone or a clarinone. If you do that, it transforms your outcomes. And I'll spend a lot of time later on today in the second talk going through the tablets. But you can see if this is heart failure rather than dilated cardiomyopathy. If you look at annual mortality with no treatment compared to the mortality if you just give those 3 simple drugs, you have a 50% change in absolute mortality. And I don't know of any other treatment in medicine that has that big an effect. So low ejection fraction, these drugs are absolutely key. This is the other thing. So your ejection fraction, if you have dilated cardiomyopathy and you start on these medicines and look again 6 months later, on average, your ejection fraction will go up sort of 12, 13, 14%. So you get a significant improvement in the strength with these tablets. Okay, device therapy. This is the left ventricle. This is someone with left bundle branch block, and you can see the different bits of the heart are out of sync. They're all beating at different points of time. So if you have an ejection fraction of less than 35%, left bundle branch block, and this sort of desynchronous heart, putting in these CRT pacemakers or defibrillators is a really effective treatment. So this is a normal pacemaker for a slow heart rate. That's the atrium where you have one lead. You then put another lead in the right ventricle. So that's it. And that comes up to a box that just sort of sits under your clavicle. So that's a normal pacemaker. That's what we do. That just monitors the heart. If it goes too slowly, it just kicks in and paces the heart. For this resynchronization, we put a third lead down this coronary sinus, which is a vein. That then comes up here and sits over the left ventricle. And what you do then is you pace the left and right ventricle together, and it makes it much more synchronous. So the symptoms improve and risk of dying is cut by about 30%. And that's cardiac resynchronization therapy. And that can be a pacemaker or a defibrillator. Defibrillator is the same process, slightly thicker leads, bigger box. And as well as pacing the heart, if the heart goes really quickly, it can give the heart a shock to restart it. Okay, and defibrillators, if you don't have the bundle branch block, then you can have just the two leads like the pacemaker, but as a defibrillator. Doesn't help your symptoms or help the heart get stronger. But if your heart goes so quickly that there's a risk of sudden death, it can give your heart a shock and restart it. So if your ejection fraction is less than 35%, once you've been on good treatment for 3 or 6 months, then that is something we would consider, and that's a conversation you should have with your medical team. Transplantation is the option at the end of the road for a very small number of people with dilated cardiomyopathy, and really very small. There's not many transplants in the UK. There's probably about 100 a year, and a lot of people aren't suitable. But the one thing we do see is often people are referred a little bit too late for this. So if you're one of the few people that has bad disease, so if you're in and out of hospital more than once or twice a year, despite a defibrillator and all the right treatment, it's much better to be referred early, so you can be there in the system if things get worse later. Well, if you leave it too late and there's liver and kidney problems, then you do miss the window sometimes. So if you're really struggling with your disease, then maybe ask your medical team for that conversation. Rehabilitation is really important. Everyone with dilated cardiomyopathy should see if there's a local rehab group they can join. A bit harder with COVID, but there's a lot of virtual stuff they're doing at the moment that's really good. This is just looking at the course of heart failure. And what you have is this trajectory where at some point, sometimes things do get worse. And all the drugs do is just move that to the right. So they're postponing things rather than curing things sometimes. But there are some people, as they get older, where things do get worse. And I think it's important to have the discussions about end-of-life issues, turning off defibrillators, wishes earlier rather than late while you're well. Hard discussions to have, and for the vast majority of people, you'll never need to have them. But if things are getting worse, I think it is important to have those discussions. And again, medical teams tend to have those discussions too late. Much better to have them in advance to really go through things properly. And palliative care teams aren't just for people dying with cancer. They have enormous resource. And if you're struggling with your disease, doesn't mean you're dying, that they can be a really helpful resource. So just worth thinking about that. I'm going to just do a few minutes on COVID before I go to the questions. So one of my roles has been leading the sort of COVID recovery across London. So we've been very involved in this, and the risks of catching COVID is dependent on where you go rather than your heart problem. So the social distancing, avoid public transport where you can, but it's wear a mask is sensible, but hand washing, it remains the most important thing. I'll come on to the risks if you do catch COVID. Hospitals are safe now. We've got really good procedures, separate pathways, really good infection control. If you're unwell, you should go to hospital. It is safe. But what we've seen across the world is a lot of people with heart problems are having major issues because they're too scared to come into hospital. The risks of staying out of hospital are much, much higher than going into it and getting the appropriate treatment if you're unwell. So hospitals are really safe. They've got really good procedures. If you're not well, you should come into hospital and see someone and have the appropriate treatment. Really important. And what we're seeing across the whole of Europe, people having bad outcomes because they're not coming into hospital when they should. And just a bit about new ways of working. So virtual conferencing is really helpful now. We've got these sort of video conferences we do with patients. And that just saves you having to come in. And so we can see you, talk to you, and get your blood test done locally. We can mail out monitors to put on. It's worth you guys buying a blood pressure monitor so you can keep an eye on that. So we can do a lot of this virtually these days. And I think, COVID hopefully will be sorted at some point, but I think we'll continue with that way of working going forward because it just seems a much better way of working. A lot of people are worried about risk of dying with COVID, and the data is hard with this. This is I think the biggest thing we've got in this country. So this is 23 million GP records. And you can't see this. The absolute key predictor of death with COVID is age. So this is above 80, 70 to 80, above 60. That trumps absolutely everything else. If you look at chronic cardiac disease, which is here, the risks aren't that high, actually. They're a little bit higher if your heart's very weak or if your pulmonary artery pressures are high, but it doesn't put your risk up that much. It's all about age, obesity to some degree, ethnicity and being male pushes up a bit, diabetes pushes it up a bit. This is transplant and things, but age trumps everything. The fact that you have dilated cardiomyopathy doesn't put your risk up that much. And what's the risk of dying with COVID? We really don't know. So this is Wuhan data. And you only test those at the beginning that are sicker in hospital. You think you've got a very high mortality. Then as less unwell people come in, it drops. You start looking at screening in the community, it drops. You screen asymptomatic people, you find more and more people, it drops. So I think the best guess is probably a mortality of about 1%, I think. But that's a personal opinion, and please don't quote me too much on that. New therapies, different types of pacemakers and defibrillators. Stem cells, I haven't seen much yet, but these microRNAs, looking at regenerative therapy for that, are really exciting. This is a heart attack. This is with the regenerative microRNAs, and just some staggering results in animal models at the moment, but that's really exciting work going forward. And the new professor just started at King's College, who's moved from Italy, that's going to be leading on this. So it's a really exciting, I hope, for the future. And then last slide, what should you do as a patient? Really important, this. So, you must see the consultation as an equal partnership. We're doctors, but our job is to do the best for you. So it must be an equal partnership. Always carry your letters and your medication. Take a picture, put it on your phone. We need to know the drugs you're on and the doses and how often you take them. Have that everywhere you go. And if you've got a phone, put it on your phone. Take a picture of your ECG. Take a picture of your last clinic letter so it's all on your phone. Write down your questions beforehand. Understand your disease. Use fantastic resources like Cardiomyopathy UK. People who understand their disease ask questions, understand their medications. Their outcomes are definitely better. You should be seen by appropriate people. If you have a cardiomyopathy, you should be seen in a proper inherited cardiac disease clinic, I think, because I think you will benefit more, or at least within a network where there's an infrastructure. Use the charitable support that support them as well if you can. Okay, so that's the end of the presentation. Sorry, a tiny bit longer than I thought, but I hope that was helpful for you. I'm just going to spend 10 minutes going through the questions now. I'm going to have to move my screen around a bit. Okay, just move that. Okay, so the commonest question is on exercise recommendations. So I think this is, there's overarching recommendations that change quite frequently. The key for this is it should be individualized for you as a patient, because it depends a little bit on the type of cardiomyopathy, the cause of the cardiomyopathy, the tablets you're on, your other problems, whether you have devices and things. Best way to do this is to join a local rehab group. So I definitely recommend that. In terms of exercise, try and do the 3 types I talked about. So some aerobic, cycling, jogging, walking, swimming is a great exercise. Some core stuff, Pilates and yoga. And then on top of that, try, particularly once you hit over 50, try and keep the muscle mass going. Very light resistance work and weights, but get individualized advice, ideally from a rehab group. The one group where we're really cautious is the right ventricular cardiomyopathies, the ARVC group. In that group, the genetic spelling mistake is at the junction of the cells. So too much exercise, particularly things like lots of cycling, can progress the disease and make things worse. So our exercise limitations are definitely different for the right ventricular cardiomyopathies. But for most people, there will be really no significant limits on exercise. Okay. So how likely are heart failure symptoms to recur for someone with dilated cardiomyopathy? So there's a lot of variability here. There's a small group, often with underlying conditions or some of the more significant genetic abnormalities where there is just progressive worsening of the disease. And there you may see initial benefit with the drugs, but then things may start to get worse over a year or two. That's the minority. I think most people, the commonest group, will present dilated cardiomyopathy, will have the right drugs and or devices. And then in the majority of those, the symptoms won't recur. So certainly I have many thousands of patients with dilated cardiomyopathy. I think the most common group I see are those that are just stable every year. Are ectopics dangerous? So ectopics aren't dangerous. Everyone gets ectopics with or without dilated cardiomyopathy. If you get a lot of them, and that's over 10,000 a day, it can make the heart weaker. In that situation, we might try and treat it. What we are more worried about is if you get runs of ectopics. So if you get 1 or 2 in a row, that's fine. But if you get 3, 4, 5, that then becomes something called non-sustained ventricular tachycardia. And that does put the risk up a little bit. So if we see that, we're more worried, and we'll certainly try and treat that, often just with beta blocker tablets. But ectopics, they often feel scary because it's a skip and a thud and a bang, but everyone with and without dilated cardiomyopathy gets them. They're not dangerous. And reducing alcohol and coffee can help with those. COVID vaccine, safe. We don't know till it's out, but almost certainly, and certainly it'll be like the other vaccines. So we'd definitely encourage everyone with dilated cardiomyopathy to have it. Left bundle branch and dilated cardiomyopathy. So maybe 20 to 30% of people with a significant dilated cardiomyopathy will have left bundle branch block. And that just means that the electrics going through that main pumping chamber is delayed. And like the video I showed, it means that heart's a little bit out of sync, so it makes the heart an inefficient pump. Having left bundle branch block is fine. We see it commonly in dilated cardiomyopathy. The key thing about it is if you have a more significant form and your ejection fraction stays below 35%, you do really well with this cardiac resynchronization pacemakers or defibrillators. So that for dilated cardiomyopathy, it just gives you another really effective treatment if things are deteriorating. So severe sweating tends not to be a symptom of dilated cardiomyopathy or left bundle branch block. So I think for that it's worth looking down the other causes, and certainly myeloma and other things will definitely much more likely to do that than cardiomyopathy. Can someone have always had a below average ejection fraction? Absolutely. So there's a big group of patients who just sit with an ejection fraction of 40 to 50%. Often lower to begin with and recovers with treatment, and then often we'll just sit like that forever. So I have a lot of patients who have had an ejection fraction, say of 45% for the last 10, 20 years, and I think at that point I don't think it'll ever change. So we do see that very commonly. If there's any other. I think they're absolutely the main questions which come. Okay, so I think we just got one minute left. So so I hope that was helpful. I think if you do have dilated cardiomyopathy and you're taking lots of tablets, try and join the later session on medication, because I think that is incredibly important. And I'll spend a lot of time going through specific tips and tricks with medicines to try and help with that. And I think we're pretty much out of time. So thank you very much to everyone who's joined. I hope you enjoy the day. Hope you can help support Cardiomyopathy UK with all the fantastic work they do. If you haven't looked on their website, join their virtual meetings. They're incredibly helpful, and their chat lines give you absolutely great advice. But I guess the final thing for me to say is just reiterate, if you're unwell, hospitals are safe, please don't stay at home and not come and get treatment if you're unwell. The COVID prevalence is increasing, and there will be a small second wave. I don't think it'll be anything like the first one. So do come and get treatment. Hard general practice is difficult at the moment, but just persevere, contact the hospitals. We're happy to see everyone. And even if there's a second wave, we'll keep working through it. So do contact people if you're unwell. Don't stay at home. That's a really important message. And I think that's probably the one I'll finish on.